This budget hearing conducted by the Committee on Appropriation and Adjudication will now reconvene with the Guam Memorial Hospital Authority. I want to thank my colleagues for joining me this morning. Joining me this morning is your Oversight Chair, Senator Dennis Rodriguez, Vice Speaker Therese Terlahi, Senator San Nicolas, Senator Nelson, Senator Torres, Senator Lee, and Senator Espaldon. I'll spare us all the speech and proceed with your testimony, Mr. Camacho.
Thank you, Mr. Chair. Good morning, Senor Speaker and members of the committee. Buenas and saludo. My name is Peter John Camacho, Administrator of the Guam Memorial Hospital Authority. I'm here today with members of our team GMHA to present our budget for fiscal year 2019. We are guided by our mission of providing quality patient care in a safe environment. As Guam's public safety net hospital, we provide care to those who present to our doors seeking medical attention regardless of their ability to pay. GMH also serves as a healthcare facility of last resort to members of our community who are not able to be discharged to home. These situations present ongoing challenges to the hospital that manifest in the lifeblood or lifeline of our hospital, its finances. Approximately 59% of the patients seen at GMHA are part of the 3 M's, Medicare, Medicaid, and MIP, and that's 28% Medicare, about 23% Medicaid, and 8% MIP, and approximately 10% belong to the self-pay category, which leads to the challenges for our hospital. Human resources continue to be a concern. The island in general is faced with a shortage of nurses, especially those in critical specialty areas. As community providers continue to focus their clinical practice on the outpatient side, there continues to be a need to recruit providers to care for inpatients. As regulatory requirements increase, there is also a corresponding need to recruit for professionals in the ancillary services such as pharmacy, respiratory, radiology, laboratory, and rehab services. Dr. Dueñas and our nursing director, Zenia Piscina, can share those details with you later on in our presentation. Funding for capital items is also a great need. We have equipment that have exceeded the manufacturer's recommended useful life, but because of our effective preventive maintenance program, we have safely extended their use. However, our patients should be provided with current state-of-the-art equipment they may need during the course of their stay. We have a need to also carry out maintenance projects on our physical plant to ensure that our facility is maintained safely. We have submitted a budget that reflects our needs for 2019, FY 2019. We respectfully request your assistance in supporting our operational subsidy request as well as our capital request. With respect.
Speaker, we have a PowerPoint that we'd like to present.
Present, please. And Peter John, if you would, on letterhead, all of you, your written testimony or your presentation submitted in writing.
Next slide.
Proceed, Ms. Mangalonia.
Yes. You're all familiar with this. The mission of GMH is to provide quality care in a safe environment, and that's what the nurses, the doctors, and the entire employees of GMH strive for. It is important to understand, next slide please, the makeup of GMH. There is the direct patient care divisions, which comprise of 4 divisions, and there's also the operational divisions. But I'd like to go over and explain the direct patient care divisions, what they do. I'll try to be as brief as possible.
Take whatever time you need.
Yes. So for the, I'll start with the medical division. And there is 6 departments in the medical division, which the first one is anesthesia, and they're the ones that are responsible for the administration of any anesthesia needs for patients that come in that needs to be sedated for any surgery or any needs for sedation, basically. And then we have the employee health, and the employee health provides employee health services for GMH employees to assure a safe and healthy work environment for the hospital employees and also for the patients that come in. They assist the Human Resources Department in pre-employment processes, and they monitor the health care workers, GMH staff, physicians for TB screening and also vaccination. They receive documents and screening for volunteers and students prior to rendering service to GMHA. So every volunteer, every employee that comes to GMH, they have to go to employee health to be screened. They also follow up on employee injuries or any exposures to, like, for example, tuberculosis. And they provide work restrictions and clearance for any employees that are not able to work. We have the infection control division, and this incorporates a continuing monitoring of patients and healthcare workers for acquisition of any infection or colonization, and they do surveillance systems. They provide surveillance of post-discharge infections, and they do investigation of infections. They do prevention and control. There also a reporting requirement that they need to ensure that are met. And there are many other services that these infection control do, and if you want more details, we have the person that's handling that division can probably do a better job in explaining what they do. We also have the quality management division, and they are responsible to review admissions of patients that come in. They conduct review of the necessity for continuing stay and appropriateness of level of care and quality of care.
Benita,
Yeah.
I know that Peter John has made the decision not to provide the legislature with a copy of the CMS report, and that when we had the hearing the other night, he hadn't even provided a copy to the board. Fortunately or unfortunately, yes, KUAM uploaded it last night on their website.
Yes.
I provided it to all the members. You might want to tailor your comments today to address the needs. All right, we've all
Yes.
seen all 78 pages.
Yeah, okay, so there will be a portion of the presentation that will address some of the needs for the CMS citation. So I'll try to be brief. And then you have the nursing division, which consists of all those departments that is inclusive of nursing, from intensive care to the surgical ward, the emergency room, and the emergency room, we have an average of like 1,300, average of 1,300 visits as of this fiscal year to date, and in the past, last Last year it was 1,300 also, and in 2016 it's 1,500. So it went down a little bit in 2017, but it seems like it's going up again in 2018. We have the professional support. The professional support handles the dietary, education, the heart project, the pharmacy, social services, lab, radiology, rehab services, respiratory, special services, and urgent care. And then under the Department of Corrections, we included the Department of Corrections budget in our submission because this was not funded for 2018, and as we were told, and we're still waiting to get paid for the second and third quarter for the DOC clinic. So we decided to include this in our submission because my understanding is, as I was told, that if this services is not funded, then it's going to fall into the CMS jurisdiction that we have to meet, CMS or JCO.
What is this?
This is the Department of Corrections. This is, we handle the clinic, if you recall, the MOU
okay.
that was in place, and GMH had to step in.
They testified it on yesterday.
Yeah,
Proceed.
so we included this in our request to make sure that it is addressed. Next slide, please. So then this the operational side is the administration, compliance, the medical staff, and then we have the operations which support the entire hospital. We have the supply, central supply, who gives supplies to the clinical areas that are needed, and we have the procurement, materials management is the one that handles the procurement. We have safety and security, the housekeeping that handles all the when patients come in and they're discharged. The housekeeping is 24 hours. They have to come in and clear and sanitize each room before another patient comes in, and so forth. We have all the other different departments here, and we have fiscal, who handles all the financial aspect of GMH, from general accounting to patient affairs, patient registration, and medical records. And it's, I can't overemphasize the, next slide please, how GMH is being paid by its patients, its payer mix. Averaging about 70% of our patients reimburse the hospital below 50 cents on the dollar. That's the 3Ms, and that's the self-pay. And then those with insurance average about 25 to 30%, and the average is 71 cents on the dollar. And that's the reason why GMH needs help. That's why it needs subsidy, because if this was a regular business, it's not sustainable. It's not going to, it won't be able to operate and do the business that it's required to do. Next slide, please. This is our resources, operational resources for 2018. Our operational revenue, we had projected at 97 million, is 91% of our budget. And what we received or was appropriated was 9.5, that's 9% of our budget. I just wanted to show that. And this is our revenue request. Based on our operation, we have the government of Guam subsidies that we're asking to cover the operations of the hospital is $40 million for the operations. And then we have the additional appropriation needed of 105. This part of this is about 103 million in capital improvement requirements that are needed. So we can go into detail on that later. Next slide. This is the projection for FY 2019, and this is how we would like to be able to operate with GMH with increased subsidy. That would increase subsidy from government of Guam of 30% for operation. Next slide. And this is showing the breakdown of the expenditures by the different divisions and allocating how much is needed for personnel services, operations, utilities, and capital needs for a total of 243 million. And one of the biggest shortcomings of GMH that we really would like this body to take into consideration is, next slide please, is our IT system. And I would like to call on Paula, our nurse champion, to talk about our electronic health record.
Good morning, my name is Paula Manzon. I was retasked and pulled out of nursing care or patient care to address the gaps and issues with our inefficient system. I know you want to hear about the citations, and I will talk about some of them in regards to our request for a new electronic healthcare record. The first slide, please. I really want to focus on some of the significant factors that affect healthcare, our healthcare team's work, and patient care when using our current electronic healthcare record. And also, CMS and Joint Commission citations and how it relates to our work with the electronic healthcare record. Next slide, please. My internal motivation in jumping into this line of work, which is not the work I was destined to do at first because I'm a bedside nurse, I saw the everyday struggles of every clinician in GMH when they're dealing with the system that we have. At present, Guam Memorial Hospital has an electronic healthcare record system called Optimum IMED, which is under Cantata Health. We also have Cerner Laboratory, E-Power Doc Emergency Room, OB Traceview in the labor room. Next slide. For Optimum IMED under Cantata Health, the company is not focused on acute care workflow. They're more of a long-term care. So their design for electronic health record is not focused to our needs. I'll give an example. We want an ICU module that will help us be more efficient in the ICU as clinicians. But they tell us, no, we cannot design that for you. So we've had this system for a while. But of course, every time we ask for modifications, they will ask us to pay a lot of money for it. This system is not part of the top 10 best in the world. So we're making do with what we have. It does not have features that aid clinicians in tasks that they need. I'm sorry?
When was that purchased?
In 2012.
Was that purchased by me? It's rhetorical because it was purchased by the hospital, wasn't it not? Who made the decision?
I wasn't there, Speaker, but I know that it was
Slide
purchased.
closer to the microphone.
It was purchased, I believe back in 2010. There was a procurement that went out, 2010, 2011, and then when the new CFO came in, it was placed on hold because they knew that it was not going to meet and address the needs of GMH. And so finally, it was implemented in 2014, if you recall, and there has been a lot of inefficiencies, and that was one of the reasons why we had problems with the billing, that, you know, it was not, they had to do a lot of modifications, and we still have, you know, a number of problems with it. And also there were there have been citations, not citations, it's from the audit, not CMS, it's on the pharmacy, and because of the previous audits that, you know, on inventory control and we engaged to implement PIXIS. This PIXIS, the hospital had been pursuing for over 10 years. And in the beginning, they said they would be able to integrate it. And then we found out that when we engaged PIXIS, and we haven't spent any money on it because they were going to start charging us once it's working, that we started that back in 2016. And then we were told that they won't be able to integrate it. So
They're not compatible and they're not talking to each other. I noticed this four systems.
They have to wait until they do an upgrade. But we had reported before in one of the hearings that we were going to implement PIXIS. It was supposed to be on last year, but it's on hold because they're not
But
talking.
as you testified, you've been trying to do this for 10 years.
The hospital had been pursuing. That's what I was told, that they had been pursuing
And
it.
you finally made the decision in 16
Because
But you now found out it's not
because
integrated.
they told us that it was going to be compatible, but then there's things that changed. The company was even purchased by another company. So these are the constant challenges that we have.
And how much did you spend on that one?
We haven't spent a penny on it. I mean, they came in and they made the assessment, and they were going to start charging us a lease amount once.
How much was spent on the Cantata system?
The Cantata, I think, I'm sure the initial is about $2 million. Maybe Vince can, because the IT department would know more of how much was spent back then when it was initiated.
Part of the history, sir, is that it started off as First Coast, then that was absorbed by Keene, and then that became absorbed by NTT Docomo. Then it was spun off from Cantata was spun off from NTT Docomo. So that's where we are right now with that.
I'm not worried about, I don't want to know who spun it off. How much did you spend? How much did the hospital spend for this system? Surely as the CFO, you've seen
I
invoice.
know because they keep adding on to it, so it's probably over $5 million. Yeah.
In programming requests.
Yeah, because there's a lot of programming requests each time there's an issue. We ask them for modification to fix an issue, so they'll come back and say, you need to pay $50,000, you need to pay $100,000 for this modification. So that has been going on there, and even the CFO flew to Guam last year when it was bought to address the needs or what the ongoing complaints that GMH has, and it's still, the doctors, the nurses, the staff are not happy with
as you're
this.
making your presentation of trying to justify this need for this $23 million, $21 million system you want, please also make it clear to the people of Guam how many millions you spent for each one of these systems that you put in today. Or as one of my colleagues put, how much you've lost by putting all these other systems in before you bought a system that was, or why something that wasn't in the top 10, even a nurse knew it, why
Because at that time, the proposal, they were asking for $15 million, and the hospital didn't have that money. And the system that we have, one of the system that we're trying to pursue, we have that company that's servicing the lab, and that's the reason why we're trying to upgrade that system so that we can use it throughout the hospital.
Okay,
This
just
system
finish
is,
your presentation.
yeah. The system is also being used by the Department of Defense hospitals.
The current slide highlights all the problems that we've had with this system. We have some pharmacy issues that have potential to compromise patient safety, incorrect dosing, thankfully we haven't had any sentinel events. We were able to catch these errors and we're vigilantly monitoring them in the pharmacy area. But it has taken a lot of manpower and work to supplement this system. Data management and keeping historical data needed to be obtained during surveys. We had a survey where they were asking us for information, and we had just gone through an upgrade, and we couldn't provide them with that information because there was something wrong in the system. Documentation, clinicians are dissatisfied because of its inefficiency. They have to do double the work to finish this task. Documentation workflow is fragmented. That means more time is spent in the computer rather than in bedside care, as well as lacking key interoperability and communication tools to fulfill regulatory compliance. And I'll go over that further on in the presentation. It doesn't have the ability to communicate and send information to and from other facilities, or the ability to connect patients with their providers, ability to connect providers to providers. Next slide, please. So the Joint Commission and CMS citations. JC has said nursing lack documentation for sedation monitoring. CMS has said lack of care plan on blood transfusion and infection control. Now, my job during these surveys at times is they ask me to navigate through the system and find them information that they need. Now, one of the surveyors asked me, because of the lack of care plans and the lack of documentation for certain things, why doesn't your EHR have a task list that reminds and prompts clinicians on what important documentation they need to complete? All the other EHRs in the States do that. I just replied, our system is not capable of doing those things. And I'm part of the design and part of the creation of the system. I have learned how far it can go, and I'm making patchwork for these things that we're missing. Next slide, please. JC has said nursing did not do initial assessment on patient bordering in the ER. There are no intuitive alerts for nurses or physicians that point out which patient need a general assessment. We have to do a workaround in nursing where we use nurses to monitor the census daily and check documentation if they're completed. So we have retasked nursing staff to do the audit instead of focusing resources on patient care. And we shouldn't be doing that. The EHR should be doing that for us.
Peter John, I read the report last night, okay? It did not criticize the fact that there was no initial assessment. In fact, they complimented the fact that you were doing the initial assessment. What it criticized was that there was no follow-up on the discharge plan. And it wasn't that it was a patient that had come in today and was going to be discharged tomorrow. If memory serves me right, and dementia hasn't set in yet, the patients that they were describing in the report One was in the hospital for 410 days. One was 110 days. And there was still no discharge plan. It didn't complain about the fact that there was no initial assessment. It said there was initial assessment. It said that they talked about, oh, we're supposed to have an every Thursday meeting to decide what the discharge was. And everybody they spoke to, the week never has a Thursday because there hasn't been those Thursday meetings to make those entries with the social worker and the nurse and everybody else. So it's not the intuitive, the way that this thing is presented. I read it last night.
I respectfully, sir, I beg to differ. We do have citations on that. And general admission specifically in the Joint Commission report. I'm very well aware about the discharge planning as well. I am heavily involved in that project. So if you want to discuss that citation, we can go over it. I do have that citation.
I am just pointing out that you've cited this one, and I'm telling you the ones that I was more concerned about was people that were in the hospital 410 days without a discharge plan, or 110 days, or someone that wanted to leave or had been told they were going to be going.
Yes, sir. And
for the presentation to come up and start with this one.
Okay. I'm trying to relate our problem with our EHR with the citations that we have. That's the goal I have here. Next slide, please. Now I want to tell you something about meaningful use and the merit-based incentive patient system. These are mandatory CMS programs that we have to participate in as a hospital. If we don't participate in these programs, we're going to get penalized, meaning we have to pay money to CMS. So I'm going to explain that. I'm not going to explain the whole program to you. It's very complex, but there are two. Meaningful use under the Medicaid incentive program is a set of documentation requirements for clinicians that we have to complete in order to not be penalized. And in turn, we also receive incentive payments back if we fulfill all of the requirements. And these are all documentation requirements. Merit-based incentive payment system, or MIPS, a program that analyzes physician quality of care and quality data management in regards to the care that Medicare patients receive. And we participated in these. We struggled to participate in these programs, but we did with the patchwork that we do every day. Next slide, please. I just want to paint a picture of how MIPS can adjust your reimbursement payments of Medicare patients. We participated in 2017 to avoid the negative 4% change in the reimbursement rate. So in 2017, since we fulfilled the requirements with our work, we're going to be plus 4% under reimbursement rate. And we continue to do that work this year to fulfill 2020. Next slide. A walk inside our shoes. GMH clinicians take care of sicker patients every day with complex issues and needs. We must balance fulfilling all the requirements of this meaningful use, MIPS, Joint Commission, I can go on, in trying to provide the best quality care for patients. We need to increase, with increasing requirements on interoperability, a function that our current EHR does not do, and we will not be able to fulfill these mandatory programs if we don't have this. The hospital will need to pay these penalties. Next slide, please. What an efficient EHR can do, I just wanted to give you a workflow. If we had this EHR, nurses and physicians are provided with a task list to streamline day-to-day work. EHR can be trusted, and clinicians do not have to worry about keeping patients safe. The organization is provided with accurate clinical data for improvement, and we can actually figure out what's going on with the patients that we have in the island of Guam. When documentation is accurate, procedures are charged and billed appropriately. And ultimately, clinicians are able to fulfill documentation requirements and are able to give their focus on giving quality patient care, which is our mission. Next slide. If we do not improve our EHR, our organization will continue to spend more on workarounds, on overtime, on resources. Our organization will have problems in meeting regulatory requirements. There will be an increase in clinician staff work dissatisfaction. Clinical work will be inefficient, and there still will be a distrust in an unreliable system, and errors in patient care may not be prevented. Thank you.
Thank you. Anything else?
Yes, we're here for questions.
As one of my colleagues just said, is that it? Because I will tell you right now, before we started, if your oversight chair had been here, I was going to clear with him, but I had seriously considered gaveling in this hearing and gaveling out. Without a hearing, but I wanted to hear what you were going to present to us today. Part of the problem that you're having with your CMS report, or at least the major part of it, because I read it, 78 pages, you have to go to page 45 before you find any mention of facility problems. And it only goes from 45 to 52. From page 1 to page 78, except for pages 45 to 52, are all governance issues. At the oversight hearing the other day, your oversight chair kept asking, do you have any board members coming? Do you have any board members coming? This morning, you have no board member here. We have no idea whether or not they've cleared this. And in spite of my exhortation the other day about it being unbelievable that your board hadn't been presented with a CMS report or had seen the response, I'm not sure if you understand the cognitive dissonance of that. The criticism was lack of governance. They hadn't cleared the response. They were complaining that GMH has all kinds of policies and procedures. They were complimenting you on that. You have a Thursday rule, you have a rule for this, you have a rule for that. They cited the rule to you. The problem was the rule wasn't being complied with, and there was nobody enforcing it. Your admission the other day, when I asked whether or not your board had seen it, and it cleared your response, I think now that they know it with all the press releases and all the editorials that have come out, that there is no board governing this ship. I'm just wondering whether or not we should even bother to have any appropriation to the hospital this year, because October 1st, you will lose the CMS. That was the criticism, lack of governance. The 7 pages that were mentioned of what the problems were at the hospital, there was nothing here in your testimony this morning talking about some quick fixes. They talked about it in their meeting when they were here in April, there was an immediate jeopardy that you guys cleaned up very quickly. I imagine that was probably the alarm system or something that you were able to take care of quickly. In the 7 pages, they talk about the problems with the exits and the balconies. No testimony today asking for it. Nothing. How much do we need to take care of what was mentioned in the report?
For the balcony, the exterior exits is $275,000.
I understand, but that's why I decided I was going to let this hearing go through. But you've said now we're done with no presentation on that. When we had that Oscar-winning production earlier this year of We Need Money, one of your division heads came in and talked about the fact that the cafeteria needed a dishwasher and had a couple of things, and that CMS was going to ding us for it because of the fact that paper plates and styrofoam plate containers aren't supposed to be used. That took up 4 pages in the CMS report. This morning, nothing.
If I may.
I'm not going to, I'm just saying, make the presentation of what you feel you need. Madeline's asking for additional time. If you're not asking us and saying, this is absolute need. They talked about the fact that there was an EHR system in place, but it wasn't the EHR that was a problem. It was the problem was the fact that nobody was complying, or at least in 9 out of 30 that they, God, what a horrible week they were here. That had to have been the worst week at the hospital, because that can't be every week. I can't believe what that they witnessed. I don't know if anybody else has questions.
Thank you very much, Mr. Chair. I echo the sentiments of the speaker, but first I want to talk to the employees. You know, all of you who are here, you've come to every hearing, whether it be the dedicated revenue fund, whether it be a budget, and it's you guys I want to thank you. I want to thank you because you are the backbones. The problems we've had over the past few years, and you've seen the problems we have, it's with the management. It's not with you. If you're not getting the resources and the right leadership, which don't take it from me, take it from the Joint Commission report, take it from the CMS report, that it's leadership that has a problem. And if you can't fix that, you're going to have a very big problem of fixing everything else. Mr. Camacho, you said that the CMS report was something that couldn't be released and the corrective action. Thank goodness for KUAM, they posted it, so the speaker had provided to us. The corrective action plan, how can we help you, for that, to help you carry out that plan if we don't know what it is? And so if you're still going to hold the line that you can't provide it to us, does the committee need to subpoena that document from you?
The other night, I believe it was either Speaker Chirlahi, Vice Speaker had asked about the release of the report. On that CMS report that you have obtained a copy of, at the very bottom of that page, it says the report, whether or not a corrective action plan is submitted, is disclosable after 90 days. So that's what we've been going on.
No, I'm talking about the corrective action, because we have the report. The corrective action, are you going to release that to us so that we know what you told them? So we know what you told them, how are you going to fix this? And how are we going to we're in the dark on how to help you, to properly help you, if we don't know what you told them on how you're going to fix it? Your board didn't even know.
I will, if you will allow me, sir, we'll check with CMS that we can release it before the 90-day deadline. And then if they say it's up to us, then we'll release it to you.
On a corrective action, I don't understand. I mean,
If at the bottom of that page that from CMS, the 2567 form or whatever it is, it says the report, whether or not a corrective action plan is submitted, is disclosable after the 90 days.
Vice Speaker, do you have any? Please, Don.
Honestly, that doesn't make any sense to me from my viewpoint that if you are trying to address, citations in the CMS, I would think you would want the entire government of Guam's resources at your disposal to really help you, to really sincerely address those things. And I don't see how you're going to do that without your board knowing what it is, without your entire hospital agreeing that is what we should do, can do. And I especially don't understand why it's a secret from the legislature, the promises that you are making to CMS to resolve issues, especially if they are going to require money. And that doesn't make any sense. But if I could, I think the speaker and the chairman has made their points regarding, the presentation and management. But I want to thank also the employees for being here. I know we all sincerely want the hospital to get better, and I still have hope. And particularly Ms. Manson, I want to thank you for your presentation. So on this particular item, I think you've been very, very clear. I want to thank you for your work. It's a very clear case, right? I hope that while you have been working on this, though, our obvious questions, I'm thinking, must have been even more obvious to you who are suffering under this system. It wasn't clear to me the answers. Who purchased this system in 2012? That was only just a few years ago. And did I understand correctly? You said it was put on hold because the CFO knew at the time it was not going to be the best system for our hospital, but they purchased it anyways? Is that what you said?
No, it was purchased, and then when the new CFO, the new CFO came in, they delayed the implementation because they knew that it wasn't going to address all the needs of the hospital. So it was implemented as he was on his way out, and
all right.
That was why we had a lot of issues
Ms. Manson,
later on.
what is your understanding of who chose this system?
I was not employed in Guam Memorial at that time. I inherited these problems.
But in your work, have you found that out?
I would love to know who it is.
Is it your understanding that in 2012 there were other systems that could have been used?
We have a multiple number of systems that are being used concurrently. So there's different systems together, and they don't exactly work with each other. So
you are advocating for this one system that is currently being used in the lab, the Cerner laboratory?
Yes, ma'am.
And how do you know that's the system you want to use as opposed to any of the other systems being used in all the other hospitals in the nation?
So I was part of the research to find a new system. The best system in the country is Epic, and we did contact them, but they weren't able to entertain us, so they turned us down. Cerner, they turned us down initially, but we begged them because they're the second best in the country. All the other systems, I feel, do not meet our current needs. And I know these systems are expensive. We're not talking about a few $1 million. We're talking about $30 million, $40 million. And I know it's a big investment. And I know everybody else here has needs of their own. But I strongly feel that if we do some kind of change, it will improve the work life that we have in giving our patients our care.
Thank you. Benita, what amount was included in your budget requests for this system?
It's 20 million, it's in the IT, I mean, the CA, included in the CIP.
20 million, are we going to be able, she just said 30 to 40.
That is for over the, I mean, it's 15 million for the implementation and execution that's needed, and then, you know, the, what is it, license requirement, and also there's going to be some hardware needs that needs to be purchased, and I think the IT administrator's here, and he can better explain the history of the old system and the needs.
Either that or put it in writing so that we can all understand immediately why you are only requesting 20 million for a $50 million system when the other obligations are going to come in for the government of Guam to pay the rest, right? Or how you intend to make the money to pay that if you don't want to request it, I don't, or if you're, especially if you're going to be able to implement this system after all your work and we get a $20 million part of it, is that usable? But I understand. I think what you have shown us is it's clearly that is being done, you know, by the nurses, by all the personnel in the hospital, that they are addressing or trying their hardest to address what they see. Do you believe that this is the priority over, for example, fixing the electrical circuit at the hospital or fixing the roof? May I just ask your opinion on that?
No, ma'am. Those would be the priority.
All right. Are you the nursing supervisor? Could you tell me what your priority is of all the lists that we've been given? And
just based on what we hear about facilities, that is the priority.
Which
is
one?
To get the electrical system and so forth. However, the EHR, that is really key. I came on board in 2015, and that was one of the first things that I recognized was our electronic health system was not user-friendly for our hospital staff, not just nurses, but doctors and so forth. And so I worked very closely with the nurses to see how we could make it work for our setting. And Paula was really key, so that's why we actually pulled her to do this, because for one, this system doesn't come with it prepackaged. We had to build the system, and it took a lot of resources, but we had to make it work regardless of, and so it was a lot of manpower, lots of nursing manpower.
Paula, may I ask, in your work on this procurement, have the doctors bought into this? Has that been?
We've asked for their input as well, because of course it affects them, not only nursing. They're the only company that's entertaining us at this time. So other people that we've called don't reply back just because they probably know our history, especially this EHR that we have, yeah.
If you have any records that show you've surveyed the doctors regarding this system or other systems, please send those in also. And just finally, I want to ask Peter John, my understanding is that someone sent me an email that says the hospital, you've got funding, or the governor's promised funding for the $5 million electrical, is that correct?
On the electrical panel?
Yes.
We brought that, as it was mentioned at the oversight hearing, we did bring that information to the governor, to governor's office, and so they're looking into what they can do.
It's not promised yet?
I can only go by what they're working on trying to find that funding for us.
What did the hospital use the money that Gita sent over for? Gita sent over money that was part of the public service donation by companies who got QCs, right? They were relieved of taxes, and in exchange they were supposed to give Gita some money, and some of that was supposed to go to GMH. So what did you use? Didn't you receive that recently? What was it used for?
That went to projects in radiology. I believe it also went into laboratory. There's a project for laboratory and dietary, and then also for the nursing for like the bariatric beds.
How much did you receive? 600,000?
About 600,000.
All right. Okay. Thank you very much.
Senator, could I just make a comment regarding the, I'm sorry. regarding the EHR. The physicians, when Optum came on, we had a particular difficult time trying to get used to it. But like anything else that's new, we expect that we're behind in the education. But after much training and working it out, we still find it not as efficient. It takes us a lot more time. We're in our computers trying to do these documentation rather than at the patient's bedside. So we do find that the current EHR is improved, but it's because of people like Paul doing patchwork, and we complain we don't have this, we do the next thing, but it's ineffective and inefficient for us, and makes us ineffective and inefficient in our work for our patients.
Thank you, Mr. Chairman. I'm sorry, ma'am, I didn't get your name. Could you restate that, please?
Paula Manzan.
Manzan?
Yes.
It's very nice to meet you, Paula.
Yes.
So, you're a nurse by profession?
Yes.
And they pulled you in to work on the EHR?
Yes.
I just wanted to first recognize the fact that it's people like you that are heroes of GMH. I'm sure that there's a ton of employees who get pulled in to basically save the day. And I just wanted to express my thanks to you and my deep disappointment to the administration. This nurse probably gets paid 1/4 of what you guys do. And this is the kind of heroic undertaking that will turn this hospital around. And you guys pull a nurse in and make her do that job that you guys should have been doing. I mean, Benita, I can't imagine this should have been on your top 3 things to be working on. And let me tell you why. For years, you would come down here and tell us that the 3 M's are the reason why the hospital's drowning, and we need to increase the Medicare reimbursement rates, and we need to fly out and go out there and lobby to get that done. And now here we are, we're going to actually lose the whole thing. How can we go out there and make a case for an increase in the reimbursement rates when the reality is that the system is so broken that they're going to take away everything? It's astounding. And I've been here for 6 years, and you guys have been here for a while too, and you know that you came down here and made that case over and over and over again. The reason why the hospital is suffering is because we're not getting reimbursed the same rates that they do in the States, and until we can get up to that level, we're just not going to be able to get anywhere. And yet, since 2012, we've had this problem, and it never got fixed until you pulled in a nurse who hasn't even been here when the system was actually established. It's incredible. That's the kind of management failure that CMS is talking about. That's incredible.
May I respond?
What's incredible is we wouldn't even have found out about any of this stuff. I mean, you wouldn't provide us the CMS report. Everything that we've been hearing up until just these past few weeks have been about increasing a sales tax and wearing black armbands to create a sense of urgency, parking a hearse out in front of the building, and yet all the rot is inside. And then it's amazing because a very prominent physician just posted very publicly about how the record system is fixed, and yet we get something very, very different today. And that's the kind of inconsistency that's very alarming in GMH. Because why are certain groups saying one thing and other groups coming in and presenting something else entirely? It's that internal political turmoil that's killing the agency. So, ma'am, I wanted to thank you for your heroic undertaking. I'm scared to even ask how many millions of dollars we may have lost over all these years because of this system. I'm certain that we probably saved hundreds of thousands, if not millions, because of your work. And I'm certain that your testimony here today is going to result in us fixing a problem that you got stuck with that's been around for years. And it's amazing because all the talk gets political and they turn around and they say, oh, the legislature's not supporting the hospital, but this has nothing to do with appropriations. All we do is we appropriate to you guys. We don't even tell you how to run your operation. That's what you have a board for. A board that you keep completely in the dark. And as the chairman mentioned, these citations are all governance issues. And this legislature does not govern the hospital. All of these items in this presentation, starting on page 6 concerning the electronic health record, are all management issues. And amazingly, in the GMH budget hearing, the nurse who isn't an administrator, who got stuck with the project that should have been dealt with for years, comprised half of the agency's testimony today. And Mr. Chairman, I'm just at a loss because in knowing all of this information and knowing that it's a governance issue and knowing that this body does not govern this hospital, aside from dealing with it in appropriations, how do we compel this issue to get fixed? How do we compel these problems to get fixed and this behavior to change?
May I respond?
Please.
Yes. Because, if GMH had been funded all this time, we would have been able to procure that system in the right system in the first place, but it didn't. So it had to contend with what it had, what resources it had. How much did you give GMH for 2018?
This was my first time ever, Benita, seeing any presentation.
Senator,
this is my first time, Benita.
Let me finish, please.
This is my first. You're mentioning about when.
Yeah,
how come we never fixed it?
If I may, let me finish.
Benita, let the senator finish.
This is my first time ever seeing any presentation in all these years about the broken electronic health record system. So you can't say why we never funded it when I've never seen this kind of a presentation before, and it's very well done. It's incredibly well done. I mean, even to the point where she points out that we're going to lose money if we don't do certain things, and that we're going to compromise patient care
correct.
if there isn't going to be these things done. And so this back and forth has got to stop. This is the kind of work that you should have been doing years ago, and it hasn't gotten done. And a nurse got pulled in and did your job for you. And I'm grateful that she did it, because otherwise we would be totally unaware of these facts, and we would be staring a CMS loss in the face. And the narrative, if all of this information didn't come out with all of these brave people, the narrative would have been, the legislature didn't give us the money and that's why we lost accreditation. When the reality has now proven very different. And it has not only proven very different because of the facts that were brought out over these last several weeks, but it's proven very different in that these facts illustrate a problem that has started all the way back into 2014 and 2012. All those years that you came before this body and you demanded more money and you asked us to borrow more money for GMH while completely ignoring the problem. We borrowed, what, Mr. Chairman, $40 million for the hospital? We paid for vendor back payments. We gave you an extra $14 million to buy your wish list of supplies, and then we advanced another $14 million for the next year's supplies, because that was what your quote-unquote priority was at the time. You could have bought a new health record system. You could have come down here and said, we need the money for a health record system, but you didn't.
I have, Senator.
So
I have asked for money for IT.
So let's
But it has been ignored.
Let's end this back and forth.
I came to GMH 2015. There's that the request for the IT was requested in 2016 with that 175 million project that we were trying to do. 125 was for CIP, and the rest was for the operation of the vendor payables. We did ask. We've been asking. So don't, you know, I know you sit up there, you're all very powerful and, you know,
Benita,
trying to
stop.
shut me down. It's not fair.
Senator Torres. Senator Lee.
And it was leadership that asked
you,
Paula
Mr. Speaker.
to create that team to help us with the meaningful use, with the MIPS. We recognize what we need so we don't lose CMS money next year.
Thank
We
you very
provided
much.
the resources, so please stop berating us here.
Thank you, Mr. Speaker. Ms. Manglotnya, can you just please walk me through again this timeline for the procurement of Optimum IMED? So there was a 2010 procurement, is that correct?
I would. That's why I had asked Vince, because I wasn't around, and he's more familiar with the details.
Okay.
Good morning. Good morning, Senators.
Good
I'm
morning.
Vince Kichichu, the Hospital IT Administrator. Yes, history on this current EHR system. Back in December 2010, under Purchase Order 2011-1296, the hospital purchased from then the company was called Keene Incorporated, a certified meaningful use 1 EHR system, and we call it Optimum IMED. The review process for getting that purchase, there was actually an IT steering committee in the hospital chaired by a board member at that time, and also the co-chair was the Associate Administrator of Operations at that time, IT, myself, representatives from the ancillary and nursing departments. It was a 9-member IT steering committee. We had reviewed 3 prospective EHR solutions, one from Cerner at that time, one from Keene Incorporated, when they were called Keene Incorporated, and another company called Blueware. But because of the cost of these 3 systems, they actually gave us proposals. The most cost-effective solution at that time was with Keene Incorporated, now called Cantata Health. The cost for that system was $2.3 million. I don't recall if the hospital at that time requested for any funding from the legislature to purchase that. It was purchased through hospital funds.
So, Mr. Kichichu,
But it was also purchased with a 5-year total cost of ownership at a 5% interest rate per year.
I see. So in December of 2010, the procurement went out.
Yes.
And then you received responses back from 3 companies. The IT steering committee convened and reviewed those 3, and then when did you make your selection?
December of 2010.
December of 2010 is when you made the selection.
Right.
Okay. And the CFO at the time, according to Ms. Manglotnya, wanted to delay the implementation.
No. The
Can you walk me
CFO
through that?
at the time we purchased it, the CFO was Peter John, but the implementation of the system was CEO, stand corrected. But it was going to take 12 months at a minimum to implement this system. So during the actual installation and testing and training and all of that, administration changed. We had a new CEO and a new CFO. When they came on board, they actually wanted us to stop the process for almost 2 years. In the meantime, because of our 5-year total cost of ownership, the hospital was being billed on a monthly basis. So they actually put the hospital on credit hold because hospital had not paid for almost 24 months.
Mr. Kichichu, one of the questions that I have is this IT steering committee, were they able to identify some of the issues that we're hearing from Ms. Manzon and others now? Were they able to identify that this system didn't meet the need?
No, because we weren't even using that system yet because we hadn't purchased it yet. All of these
But wasn't it
findings
part
by
of
the findings by the nursing, the end users, the physicians, the clinicians, the ancillary folks, was after we went live and they started hands-on using the system. That's when they start finding the problems and the difficulties in using this system.
When you issue the procurement, you don't identify what the needs are for the hospital so that the system meets the need?
Yes, in fact, there was it's called an abbreviated system decision paper that identifies the need.
Right.
This was like a 5-page. We actually gave the speaker the whole documentation on this purchase several years ago. I don't think he was a speaker yet, but we can provide the legislature with those documents again.
And when was the system, the initial payment made for the system? You were talking about a 5-year implementation and you have to make payments
On a monthly basis.
on the monthly basis.
Yeah,
So-
they were billing the hospital on a monthly basis.
So the $2.3 million was just the initial payment and then you paid monthly
No,
for the
that's-
use?
The 2.3 million was the total cost of ownership.
For this EHR?
Right.
And that was made on what date?
That purchase order date was December 29, 2010.
But it wasn't implemented until 2014,
Right.
is that correct?
That's correct. February of 2014.
So in the time span between December 2010 and February 2014, you were making tweaks to the system so that it would fit GMH's need better?
That's correct. You know, we're going through the implementation phase of building the system like head of nursing, Ms. Zina, mentioned earlier. There was a lot of work by a lot of the team members to build this system, you know, build the tables, define the screens, the menus, et cetera, because it was a very, it wasn't a very user-friendly type system. We had to do a lot of work to build it to the hospital's needs.
I'm just trying to wrap my mind around the idea of purchasing a system in December 2010, not implementing it until 2014, and having the CFO delay implementation of a system that we knew didn't necessarily meet our needs.
Yeah.
And I'm trying to figure out who benefited from this? Who was the recipient of this money of a system that doesn't work for us?
The reason why the CEO and CFO at that time asked us to put a hold in the implementation, they actually wanted us to look at Cerner at that time for their EHR solution. They brought in that company on site for 3 days. They did demonstrations to
And
everybody,
according-
practically everybody that's still in the room that was still there at the time.
Okay. According to Ms. Manzon, this is the same company that we're now trying to approach.
Yes.
Correct?
Yes. But at the end of that demonstration, I guess the proposal at that time was way beyond the hospital's or the government of Guam, I guess, affordability. So they scrapped it after seeing all that and looking at the estimated costs for going with the Cerner EHR solution.
Okay, and then I just want to go back to the priority listing that was sent down to the legislature, GMHA priority needs. On page 4 of 6, IT is listed out. And when you kind of add all of this up, it comes to a grand total of about $19.5 million. And 17.2 would be for element execution cost, with total cost of ownership over 5 years to include licensed software, implementation services, application management. So this is the system that we're talking about now.
That's correct.
Okay, so it's 17.2 million, and Ms. Manzon had mentioned a $30 million price tag. So which is it?
The initial cost for the first 3 years is $17 million, but because we were asking for a total cost of ownership of 5 years, with the remaining years and of course the interest applied, it'll cost approximately $30 million.
So it's almost double what we're asking for here.
Yes. But you know, there's nothing firm yet. We still got to negotiate with them after making sure that we follow the procurement process, the procurement rules.
And Ms. Manzon, I also want to thank you for your work on this. I wanted to ask, the Cerner system, it will meet all of the qualifications that were listed in some of the issues with the CMS report?
Yes, absolutely.
Okay, so it provides the clinicians, the nurses, notifications on certain steps in their process?
Yes. Our biggest problem is communication, I think. And that's something we've been asking for from this current EHR system, but they haven't developed it yet. They're kind of in the baby stages of creating an EHR, and we don't want to be the ones developing their system for them.
Absolutely. Well, if we're going to pay them $17 million and, $30 million at the end of it, we want to make sure that it works for us and we're not working for it. So I understand that. In the current system that we have now, do nurses and physicians have to input information and then chart again on paper?
Yes.
So it's
I'll give you an example.
Okay.
In the EMR system, we could not rely on what was on the screen of the correct medication, so we had to keep the paper documentation with it, just to make sure that we were keeping our patients safe. So that was a really big discrepancy on their part.
Thank you. I have a number of other questions, but I want to give my colleagues an opportunity to ask theirs in this round. My last kind of question or comment to you, Mr. Camacho, is we had, I think it was a working session a few months back, and we had asked you for a list of priority needs, and you provided that in 6 pages of GMHA priority needs. And I understand that the hospital has a lot of needs, but it really would be helpful for us if you could identify what is the absolute most urgent thing. Because I see, rapid infuser for $40,000. We see Omni beds. We see $20 million for hospital parking structure project. And we've heard that facilities are some of the issues that need to be addressed immediately. And it's just really difficult for us to get a sense of the full picture, what the absolute most urgent needs are, and then the things that might be able to be handled in the next few quarters, in the next few years. This is still really difficult for me to wrap my head around. So if you could maybe provide it to us with priority needs 1, 2, 3, or something along those lines. This is something that we've asked for months, probably for years, and we're still not getting that information.
I'm sorry, ma'am. I believe it is in the budget packet as presented to the legislature, and it talks about the priority needs. Excuse me.
I have 6 pages of priority needs, so
There are several. Hold on. Yeah, there's a lot, but let me find that for you, Matt, and I'll show you later.
Thank you, Mr. Chair.
Thank you, Mr. Speaker. I do want to thank all of the GMH employees for their hard work. As the chair of the committee stated, the challenge really is to address the issues of the management of the hospital. It has nothing to do with the employees or the nurses. You are the backbone of this hospital, and you are what keeps this hospital running. I do have a question. In the PowerPoint presentation, if you could pull up this slide, it shows a list of an icon of individuals below 50 cents, below 71 cents.
This one.
Can you see that back there in the AV room, this slide right there? And I wanted to ask if you could just explain this slide one more time.
Okay. Hang on. Janelle?
Can you bring that slide up?
Yes.
Thank you.
So about average of our patient, this is our payer, the payer mix. Our patients that come to the hospital. And in averages between 55 to 60% are the 3Ms, Medicare, Medicaid, and MIP. And they pay below 50 cents on the dollar. Then you have your self-pay, which is, averages again 15 to 20. It changes every year. And they pay less than 50 cents on the dollar. So you add those group, that's the group that reimburses the hospital less than 50 cents on the dollar. And then you have the insurance company, which averages 25 to 30% of the payer mix, and they average about 71 cents on the dollar payment to GMH. So it's just illustrating the patient mix at the hospital and how the hospital is being reimbursed. So if you have a business that operates and do not get the full money that you're charging, then that business is not gonna be able to continue operation. This is how GMH has been operating.
Thank you, Ms. Benita. I know I sat down with you several times to really understand the payer mix, and the 3Ms. But my question is this below 71 cents on your slide, this is 25 to 30% of your payer mix, and it comes from the insurance companies?
Yes.
Why are they paying less than what is owed?
It's, you can't find anywhere, any hospital that gets paid 100%, because not all services are covered. So there has been that allowance there. When a patient comes in, the doctor treats the patient. They don't stop to pick and choose what services are covered, what benefits the patient has. Mm-hmm. So they treat that patient, and so after the patient leaves, or before they leave, they're presented their interim bill.
So the remaining, what is this, 29 cents? The remaining 29 cents of every dollar at GMH that is owed
it's lost.
Is specifically from the inability of those, of the perhaps the medication or the care given to the individual that is not covered by the insurance?
The insurance, yes.
The whole 29 cents?
Yeah.
So then that would be included into your self-pay portion?
It moves to self-pay.
So you are collecting everything that the insurance owes to GMH. You're collecting every cent on the dollar. The challenge is...
Not necessarily, because, the self-pay, they don't pay everything.
Right. The challenge is the self-pay piece that the insurance doesn't cover. But if the insurance does cover it, then you collect every cent on the dollar.
If they pay everything, if the services they receive are all covered benefit, then we get everything, but that's a rare occasion.
No, I'm asking. I'm not asking about.
I'm talking. When we present this, we present averages, and the allowance in any given year is for the 3Ms. We're talking about over $40 million, and with everything, with self-pay, it averages between 65 to about 70-some million, because we bill out about 100 the last 3 years, over 150 million. But we recognize revenue of about 80 to 90 million.
I just want to make sure that the illustration that you've presented, where you put below 71 cents that the insurance pays out, that 71 cents is everything that is covered by the insurance that you're able to collect. And so everything that is covered by the insurance, every cent on the dollar, if I'm covered, that is what is collected, that all the insurance companies are paying the hospital the fair share of what is due.
Well, that's why we bill and we meet with the insurance.
But is that a yes, or is that it's not able to happen?
Like I said, the average of the insurance pays, these are averages for all the payers. Some insurance companies pay much less some pay higher, but when you add everything and you take an average what's paid in the year, that's the average, and you can find this in the audit report. It's reflected on, I think it's almost the last page where there's a spreadsheet of all the different payer mix, and it shows how much is being paid, how much is billed, and how much is being paid.
Okay. Okay, thank you. One more question. I'm a little bit perplexed because my colleagues have mentioned that there's the governing board, and the CMS report specifically states that there's lack of governance within GMH. And so I'm perplexed because I'm wondering, statements are made that the board members are not aware of the challenges that the management is facing. So how is that happening? And I think that if GMH is really truly governed by the board, that the board should be here answering these questions. Where are they? I'm at a loss. I'm a little bit confused. Were they invited?
Yes, ma'am. They knew that we had our budget hearing today.
Do we need to subpoena them to come?
I don't believe that you would need to do that, but as was stated at the oversight the other
I'm
night.
seeing people smiling in the background, so I'm curious what is really going on here.
As stated at the, by our trustees who were there at the oversight, ma'am, they did say that, they are working, and so, they have conflicts sometimes, but on Monday night...
Do we need to consider to replace some of them because they're not able to give their full attention to the needs of the hospital?
They're a good board, ma'am. They're a good board, and...
What is the definition of good board? Is the definition of good board staying out of the way and allowing the hospital to function in any which way? Or is it a good board perhaps provides the checks and balances and ensure that the hospital is functioning in the best interest of the people of Guam?
Your second description?
Okay. Then it really contradicts the CMS report, if that's what it is. I don't know. I think that's something that needs to be looked at for the oversight chair. Thank you, Mr. Speaker.
Can I just...
if you've watched the earlier hearings, DOE has its chairman come, GCC has its chairman come, or a board member, GCC had. Your chairman had to ask you the other night where your board members were. You have a very good board member in Ms. Weibel. Ms. Weibel is so interested in the hospital that years before I asked about certified billable coders, she was at a public hearing at GMA at the old building before she was a member of the board. And we were talking about problems of collections at the hospital. And I was looking out to the audience. I could see that there was something on her mind. So after the hearing, I went and I spoke to her. I said, I know that you run a health clinic. What do you recommend? She was the one that planted in my head the idea of certified billers. I didn't know certified billers, but I could look out and I could see the expressions on faces, and I could see in the back of that she was like. So I purposely went up and I asked her, and she told her. And that's why for years you and I have been going 3 or 4 budget hearings of, do you have certified people? And yeah, finally. But I'm just telling you, that woman was concerned enough to come to a public hearing. When she wasn't a member of the board, she was just a member of the general public. And she was kind enough to stay afterwards, after I looked at her to please stay, and I went up and I asked her. And she was the first one to respond the other day when the chairman asked. Like in some of the other boards, it may not be the chairman that shows up, right, but another board member. Right. Just show that there's governance. But Senator Espaldon.
Thank you, Mr. Chairman. A lot of the comments have been made that I probably have to agree with, and also a lot of questions have already been answered. But Ms. Manzan, on your presentation on page 9, under the MIPS section, the Meaningful Use Merit-Based Incentive Payment System, you know, again, this is the first time I've heard of this system. However, in the very first bullet point, you make a statement that GMH has struggled in the past year to meet all regulatory requirements of these mandatory programs. You specifically say past year. And so the question arises in my head, was there a struggle in previous years, or has it just been in the past year or two?
In 2016, we pursued meaningful use. And if you understand what meaningful use has been, it has been around for a few years already. Now, Guam Memorial Hospital has implemented physician order entry just recently, and that's a big part. It's called CPOE, Computerized Physician Order Entry, and that's a big part of meaningful use. And we tried to participate in 2016, but we weren't able to meet all the requirements because of things that happened that year with the EHR specifically. We worked on it throughout the whole year, trying to figure out what we can do on our end, and pleaded with the EHR vendor to make it what we need, basically. And we were able to fulfill those requirements with a lot of work during 2017.
Okay, so, and then again, specific to my question, again,
yes.
You're very specific that just over this past year, but not the previous years.
Not the previous years. We pursued meaningful use in 2016. We didn't make it. Okay. We did in 2017 for 90 days from October to December. We submitted that early this year, and we were able to garner $1.04 million for meaningful use. And then we submitted our MIPS in March with the help of Ms. Manglotnia. We were able to basically meet all the requirements so that we don't get that negative 4% change in the reimbursement rate.
Okay. No, I appreciate that. Thank you. I was just trying to get a little more understanding of how that all comes down to just a one-year struggle as opposed to multi-year struggle. But
I have not been doing this for all of my nursing career.
No.
I was a telemetry nurse from 2011, and I came into this in 2015.
Ms. Manglotnia, it looks like you want to say something.
Yeah, I want to say something. When we didn't meet the meaningful use requirement in 2016 because of the deficiency of the system, we appealed the decision. We appealed to be able to be given the opportunity because it was the hospital tried, but because of the shortcoming of the system, you know, we were not able to meet that, and then they allowed.
So you couldn't participate, bottom line.
Yeah, we could.
But you opted out of participating.
Yeah. No, they did not. You know, we didn't meet it, so we were able to attest the following year, and so we didn't lose out. It was just delayed by a year because we didn't meet it. So now we're going to attest for 2018, and that's about $750,000.
$750,000 for meaningful use, if we do meet all the requirements, and then for MIPS for this year, it will be a 5% additional to our reimbursement rate for 2020.
And you know, I want to echo the struggles that we had to pull nurses to be able to work a lot of time to meet this requirement. And you know, Paula is the nursing champion for this project.
I think that point has been made. I mean, and again, it's been said, and we definitely appreciate that. And I think Senator St. Nicholas was right. Or actually, all of my colleagues who spoke to that issue. It's like, that's an incredible feat, considering this is not really their line of work. And they're just kind of really trying to help in whatever way possible that they can And so, again, thank you for that. Another question I do have, and maybe it's for Peter John. When it comes to radiology, I know that, what is the status? We have no MRI, is that correct? All right. What else are we limited on in terms of the radiological equipment that GMH would like to have? Maybe Dr. Duenas, you look like you'd like to speak.
Thank you. We do not have an MRI at GMH at this time. We do have a 10-year-old angio suite, which is inefficient and not effective to handle interventional radiology and cardiology at the same time. But we are trying to make best we can with the 10-year-old angio suite. So we are hoping that we would purchase or get funded for a angio suite to augment the cardiology as well as the interventional radiology services that we have at GMH.
So you're specifically speaking just to the angio suite?
Yes, sir.
I guess what it comes down to, and really the question I'm going to try to get to, and again, somebody please answer, we do have a radiologist on board at GMH, is that true?
We do have two radiologists. One is an interventional radiologist, and the other one is also an interventional radiologist, but primarily with diagnostic capabilities.
And the reason why I bring that up is because I remember about a year or two ago, I saw a breakdown of what was being paid to these radiologists. Is there a ballpark figure that we could have in terms of what they're getting paid? And the reason why I bring this up is because when I saw that figure and I ran it by some trusted people who understand medicine and operations, the point that was being made to me was that, first of all, they're way overpaid for the type of equipment and type of services that we have at GMH. And so they were puzzled, again, my mentors, right, as to why we were paying such a high salary for radiologists that probably belong, I mean, it should be paid that amount, but for a hospital that's fully equipped with all the, bells and whistles in a major city. And yet here we are paying them that same high price when we don't have the full equipment for us to be able to utilize their full services.
Interventional radiology has been present at GMH. We are now trying to make it at the standard of care, and that we need to have equipment for that. Cardiology has been present at GMH. Since 2010, we have done, when Dr. Concepcion came, GMH was prepared to do cardiac surgery, and it did. Now that heart project didn't go through, and so that came to a halt. In 2018, we are now again doing cardiology services, including catheterization and percutaneous coronary intervention as the standard of care for acute heart attack. So we have done about 47 of those. We have done 9 of those since 2018. So the services has been there. We just want to improve it for better patient outcomes. Now, you came to the radiology. You want to know about the compensation of radiology?
Right.
Okay. One of the radiologists is getting $480. The other is about the same. The 50th percentile for radiology intervention is about, across the nation, is about $456,000 to $500,000. So these radiologists are being paid right around that 50th percentile.
No, and
so,
I can appreciate that, Doc. I guess, the concern was that we're paying these radiologists without even having the necessary tools for them to be able to fully, for GMH to fully utilize the services that they are capable of. And I don't know. I just needed to bring it up.
There's no question that we can maximize our utilization of interventional radiology and cardiology. We have it, it's existent, we have room to maximize it. That will take a little investment, though.
What's a little investment?
If I recall, the new Andrew Suite's around $4 million.
Okay. I have a few more, but I'll stop for now. Thank you, Mr. Chair.
Please, Senator Nelson, and then you want to finish your questions because I'm ready to recess. Go ahead.
Thank you, Mr. Speaker. This is just in relation to your collections. Again, I didn't get a straight answer, and maybe to clarify, in previous testimonies, I recall that Ms. Benita, that you said that sometimes you would have to work with insurance companies to get paid, and a certain discounted payment was given. And so I want to know, again, out of the 71 cents to the dollar, how much of that, or even the dollar itself, how much is discounted, and how much and which insurance, and the cost of discounts that you have given the insurance companies?
The discount was in previous years.
Mm-hmm.
And then when I came on board, we worked on negotiating a new contract with insurance companies, and that one was stopped in 2016.
Okay,
so we don't
from
give
what time
discounts.
period? What time period did you allow this negotiation to take place?
I don't negotiate with insurance companies for discount.
Okay.
But let me, please,
You just said you negotiated it, so I'm asking.
Negotiated the contract for
Okay.
services. Provider agreement.
Okay.
Because the provider agreement that was in place at that time was like almost 10 years old. So we updated the provider agreement, and because of the issues in which insurance companies were taking discounts when they were not entitled to, so we removed that, and we came up with a template for all providers. So we have one contract for all the providers.
So it's the same across the board for every insurance?
For every insurance, yeah. There's no
It's
discounts.
leveled?
Yeah.
There's no disparity between different insurance companies?
There are, challenges with some of the providers where they're very aggressive they send out claims to the states to have the claims scrubbed to see which items that they think that they can deny and they don't pay, but we have our staff that go through these claims, and if a claim is denied, and then we feel that it should not be denied, we return it. And then we have been meeting with insurance companies to reconcile claims, and we return claims back, and we rebuild that, you denied this, but it's not a proper denial. It needs to be paid.
So the discounts went on for some time?
That was in place for some time, but we have since removed.
When was that?
2016.
2016?
Yes.
Is when you removed that?
Yeah, we had the provider agreement was effective. I believe it was June 2016 was when we put it in place. It took us a while because we were meeting with each insurance company to negotiate and have them agree, and it's not easy to have four providers agree on one contract. So they each all had their own issues that they wanted to put in, but we told them.
But now it's across the board. All providers have the same agreement.
That's correct.
Can we get a copy of the provider agreement?
Of course.
Thank you.
You can ask.
Sorry, I know the other night you said the accounts payable was about 14 million.
That's correct, Senator.
Okay, what's the your gross accounts receivable?
It's about 39.
That's the gross?
Yes, that's the net, basically, because, you know, if you take into consideration all the old accounts that we still carry, but what we've been reporting in the financials is about 39 million.
That's a net or the gross?
That's net of the allowance.
Okay, so what's the gross? If that's the net,
It
what
be-
would the gross?
I'd have to go back and go through each, but
When can we get that?
I can look, provide
Today?
it to you today, yes.
Okay, with the aging, with the, on
Yes.
the aging, okay.
Yeah.
Thank you.
Yeah.
Thank you, Mr. Speaker. Mr. Camacho, can you please just clarify whether or not the board has seen or approved your request or your response to CMS?
They were provided a copy of,
So they weren't shown it prior to you submitting it and giving you feedback on it or providing their approval before it was submitted? You just sent it to them after it was submitted?
yes, ma'am.
Thank you.
Thanks. At the public hearing the other night, you said that they had not seen your response. So when did they get a copy of that?
Yesterday, I had asked my staff to send it.
Okay. Could I just follow up on this insurance providers? So the other night, Benita had said that there are certain providers that are not paying the full bill for example, the maternity ward, or they're trying to, I guess, so the 71% collections shows they are denying 30% of the claims. Is that correct? 29%? It's because of their denials.
That's the average.
Yes, so you're billing what you think is the merit claim for 100% and they only pay 71, so they're denying 30. Is there anything that the hospital can do about that? I mean, what are
Yeah,
so when they
Senator
deny
Nelson
it,
had asked
then
that.
do you turn that into self-pay collections?
No, it's not. There's some that we can't because we can't bill the patient. There's some instances where, if the insurance covers only so much, then it just goes into the allowance.
Why is that? Why can't you, well, what are the solutions to that? I know before, so you cut off the discount payment
Yes, we removed that.
But is there, the audit shows one insurance carrier's only, you only receive 71% of total billings and 55% from the second largest carrier. So there's even a disparity in collections from.
Yes, well, in the new audit that's going to come out soon, you'll see that one payer, the billing to collection is 123%. And that's because, we pursued this payer that had been
that's great.
Not paying, and we've been very aggressive in going after providers, and we've been meeting with them regularly. So our collection for the insurance went up in 2017 by about $10 million.
That's what I was going to ask. So
Yes.
pursuant to your new agreement, you've increased collections for sure.
Yes, of course, because
Okay.
we removed the 8% discount,
All
which
right.
was been automatically taken, and the reason why that.
But even with the increase, you're still showing the same percentage, 71%.
Well, that's the average.
But that was the average that, well,
Each insurance has, each payer is different.
okay.
So,
All right. Can you provide a report on that? Or when is the audit coming out?
next week. It's due next week.
All right. Does it name the payer, the providers?
No, it's just payer A, B, C,
Are you able
D.
to name those for us? Send us a report that shows that? Something like that.
I think I probably can.
All right. Thank you.
Yes.
Thank you, Mr.
Benita, in looking at your capital budget, I was just wondering, has the hospital been appraised? Does the hospital have a value associated with it?
The value of the hospital? No, I don't think so. The value of what it is now?
Yeah, I just wonder because, in this, I can see some very logical capital improvements that need to be done, but there are other things like a $20 million building structure for
Yes.
parking, and there's a catheter lab, $14 million. There's some big ticket items, but I was just wondering though, when you compare the investment, capital investment with the total appraised value, there's usually that equation that they look at. So I was just wondering, but at some point I'd be interested to know what the hospital is valued at for its fiscal buildings and equipment and the like, in the future, because it would make for an interesting.
I know that if we're gonna get that, from a professional, we
money
have to
to pay for it.
we need money
Yeah,
to pay
okay.
that, and that's not the priority
I knew
now.
you were going to say that, but I was just wondering if that was something that was existing. But, I just also wanted to say Suzus Masi to everyone for your presence today. And I know that, one of the things that we're not really capturing, I think from the point of view of a citizen out there who's not part of the management of GMH or the operations of GMH or the legislative body, is that we're really talking about Department of Health and Human Services, Center for Medicare and Medical Services, and the requirement for Guam to be compliant in order to be a provider of services in the Medicare program in connection with the Social Security Act. So what we're really talking about here is a facility that will have catastrophic implications to 59% of our population, who are the poor and the elderly. And so I hope that in all of this discussion that we really have a come to Jesus talk between the governor, the legislature, and GMH, because we're not talking about politics and we're not talking about you versus me. We're talking about what this is going to mean to our poor people and our old people. And it just kills me that we're pitting back and forth when we really need to just have everybody here. And it's not between you and us, and it's not about money. It's really about everything. And so I hope that we keep saying CMS, but I hope that everybody that's out there that's trying to understand what we're talking about understands that we're talking about centers for Medicare and Medicare services,
Medicare and
Medicaid services. Yes. And we're talking about 59% of our population on Guam that relies on these fundings from the Social Security Act, Title 18. So it's really, I think if there was nothing more serious to our island, this is the most serious thing I think we've ever had to be faced with of late. And, in this very urgent time, this very politically heated time, I think we need to just start looking at it from the perspective of we as individual components of a community of Guam. And I'm trying to be very pragmatic about it because I believe that it's all about a solution, and it's not about pointing fingers, and it's not about, but we really have to just own up to all of it. And it's not, Benita, about us not giving you funding. It's beyond that, and we know that. And the governor's office has been very silent of late, just watching us pit against each other. And I think it's time that we stop. It needs to be a three-legged stool, because this three-legged stool is what 59% of our community is relying on. I have a mother who's turning 90 very soon, and I know that she cannot afford to lose this benefit that she's paid into all her life, and her husband has paid into all his life. This is what they're entitled to, and it's up to us to not reach a point of no return where we're really just gonna might as well close shop and go home. But we know that that's not it, because this is home, and many of us have nowhere else to go. So I implore you, it's a come to Jesus time, and we need to just put our egos aside, and we need to just realize that we're dealing with people's lives right now.
May I just
All
make-
three of us,
yeah,
all
just-
three branches, well, two branches of government, the judiciary is out of this. So with that, I just want to say Sidus Maasi, and
I just want to make one positive comment, please.
I just want to end there. I just, yeah.
Mr. Espaldon has a question.
Thank you.
Thank you, Mr. Speaker. Just one real quick question, and it's specific. If we lose Medicare and Medicaid funding to the hospital, what does that translate into in terms of dollars per year?
Per year, for both of them, it's, I want to say about 30 million that's been paid into, 30
$30
to
million
40,
annually,
yes.
$40 million, $30 to $40 million
Yes.
annually is what we
Yeah.
would lose?
Yes.
Thank you. Thank you, Mr. Chairman.
Thank you. We're recessed until 2 o'clock this afternoon when we meet with Guam Solid Waste Authority. Thank you.